Hi guys, I guess I'm audible to all of you. Give me a thumbs up if I am audible to all of you so that we can get going with the session for today. Just give me a thumbs up or let me know through your comments whether I am audible to all of you. Okay, so it appears that I'm live and audible. So what we will be doing today is we will be taking up one more important topic from Harrison, which is approach to gastrointestinal bleeding. And when we talk about gastrointestinal bleeding, we divide the source of blood loss from the GIT as upper GIT and lower GIT, because the way these patients present is going to be different. If I'm bleeding from the esophagus, obviously I will be presenting differently. And if I'm bleeding from the colon or rectum, I will be presenting differently. So whenever we see a patient with gastrointestinal bleed, first thing is to differentiate them whether the blood loss is from upper GIT or whether it is from lower GIT. In medicine, primarily we are concerned about upper GI bleeding because majority of the causes are medical causes and they generally require a proper medical management in addition to the need for interventions. But when you bleed from lower GI, majority of the causes are surgical causes. So I will leave the lower GI bleeding to the surgery faculty and I will focus more on the upper GI bleeding. And then we have to obviously begin with one basic question. What is that anatomical landmark which separates the upper gastrointestinal tract from the lower gastrointestinal tract? See, when we say gastrointestinal tract, we have the oral cavity, we have the pharynx, we have the esophagus, stomach, duodenum, jejunum, right? Ileum, then the colon, rectum and the anal opening. All of that is the gastrointestinal tract. So now tell me where the upper GIT ends and the lower GIT begins. Good evening Nilanjana, Nuseba Abrak and Medic Life. Good evening everyone. So can anybody tell me where the upper GIT ends and the lower GI tract begins? That's the first thing that we need to understand before we start talking more about upper GI bleeding. What is the landmark? Which landmark separates upper GI and lower GI? If I say upper GI is comprising of esophagus and stomach, am I perfectly right or am I wrong? Gautam, welcome. Right, Satya IIMS, absolutely right. It is the ligament of triads. Ligament of triads, the attachment of the ligament of triads to the small intestine segregates the upper GIT from lower GIT. Anything that is proximal to the attachment of ligament of triads is upper GIT, and anything that is distal to the attachment is called as the lower GIT. So when you look at this image, probably you will get an idea what am I talking about. So here is a small image that you can see here. Okay, so this is the small intestine. Obviously this has stomach here and the esophagus. Okay, and then this is one small ligament originating from the right crest of the diaphragm and attaching to the duodenum. Okay, so this attachment point separates the upper GI from lower GI. Anything proximal to this, right, that means esophagus, stomach and part of the duodenum proximal to this attachment of ligament of triads is upper GIT. And anything distal to it, that includes most part of jejunum, ileum and the large colon, rectum and anal opening, will all be considered as lower GIT. Clear? This is an MCQ that I want you to remember. The anatomical landmark that separates the UGI and LGI is the ligament of triads. It is called as suspensory ligament of triads. Okay. Now, why are we so much concerned about separating the upper and lower GI bleeds? Because we can clinically distinguish whether the patient is bleeding from upper GIT or lower GIT, but for a definitive diagnosis, we need to visualize the site of bleeding. How can we visualize? By putting the camera into the GIT. If I am bleeding from the upper GIT, then you have to put a camera from the top. That is what we call as the upper GI endoscopy. If I am bleeding from the lower GIT, probably you need to put the camera from the bottom. That is what we call as colonoscopy or lower GI endoscopy, right? So when we do upper GI endoscopy, the endoscope can reach mostly easily and comfortably up till the ligament of triads. Advancing the endoscope beyond this point is a skill. Not all the gastroenterologists can do it. Maybe to some extent, as you gain experience as a gastroenterologist, you will be able to do, right? But rest part of the GIT will not be visualized by the upper gastrointestinal endoscopy. Similarly, the colonoscopy can maximum reach to the terminal ileum, not beyond that, right? So please remember now, if I do a upper GI endoscopy, I can reach till the ligament of triads. If I do lower GI endoscopy, I can reach till the terminal ileum. So I can visualize entire large bowel and a little bit of terminal ileum through the lower GI endoscopy. Whatever that is in between, means distal to ligament of triads and proximal to terminal ileum, cannot be visualized by endoscopy. We cannot pass the endoscope. Clear? Okay. So now we know the landmark, what separates upper and lower GI bleed. Now the first question is, if a patient presents with the gastrointestinal bleed, how do I differentiate whether the source of bleeding is from the upper GIT or whether it is from the lower GIT? As Nilanjana has mentioned, well, so think about it. If I start bleeding from the esophagus or in the stomach or in the proximal part of the duodenum, there are two exit routes for this blood. One, I can vomit out the blood. When I vomit out it, what we call it as? We call it as hematemesis. Hemoptysis is coughing out of blood. Vomiting out of blood is called as hematemesis. Clear? Second, this blood can also go down, right, from the esophagus or stomach. It can go into the small intestine, large intestine, and then it can be thrown out in the stool. But when it is thrown out in the stool, obviously it will be altered. It will not look like the normal blood because it will be acted upon by hydrochloric acid in your stomach, the digestive enzymes, as well as the bacterial activity, and it alters the blood, and what we pass out in stool will be coffee tarry colored sticky stool, which is called as melena. So if a patient presents with hematemesis, that is vomiting out of blood, hematemesis, vomiting blood, and if the patient presents with melena, that is dark coffee ground, like looking like coffee, right? Coffee ground or tarry sticky stools. Both of these are suggestive of upper GI bleed. They are suggestive of upper GI bleed. Kundan, it is available on the PW Medit Telegram channel. The link will be posted in the comment section soon. Okay. Now, the first thing we have to understand is what causes or what gives this coffee ground or tarry color to the stools if I have blood in the upper GIT. I have already told you the blood is acted upon by hydrochloric acid, the digestive enzymes, and the bacterial activity, right? So why we get to see, instead of seeing fresh blood, this coffee ground or tar colored stools in upper GI bleed is the heme in the blood gets acted upon by hydrochloric acid in the stomach, right? Digestive enzymes and bacteria, and they convert it into what you call as acid hematin. Acid hematin, and this acid hematin gives rise to the tar color or tarry color to the stool. Okay. Now, Nilanjan, right, absolutely right. There's a point to note here. For this heme to get converted to acid hematin, it has to spend sufficient time in the gastrointestinal tract because it has to be acted upon by hydrochloric acid, digestive enzymes, and bacteria. How much time it should spend in the GIT? It has to spend at least 12 to 14 hours of time, right? So when it spends around 12 to 14 hours of time in the GIT, the heme gets converted to acid hematin, and then you will see the melena. If it is not spending so much time in the GIT, if it is getting transferred to the lower GIT quickly, you will not see melena even when the source of bleeding is in the upper GIT, right? So there are 2 points to learn here. How much time the blood should spend in the gastrointestinal tract to become melena, and what should be the minimum quantity of blood, right? For example, I'm just doing something in my mouth, okay, like I'm using a toothpick, I hurt my gums and I bleed a little bit and I end up swallowing it. This is upper GI bleed, technically speaking. This has gone into the gastrointestinal tract. It may spend 12 to 14 hours, but will I get melena now? Right? Or maybe I'm popping a pill. While popping, it just brushes the esophagus, causes a small injury and then goes. We might have experienced it multiple times, right? While taking a pill, sometimes you feel that we hurt the chest because it brushed the esophageal wall and caused minor injury. We might have bled a little bit from there. Will I get melena now? Will I get melena now? Probably no, right? So then what should be the minimum quantity of blood loss for us to see melena, right? Time to be spent in GIT by blood to produce melena. I think Nilanjana has mentioned it appropriately. That is, according to Harrison, more than 14 hours. Most of the books mention 12 to 14 hours. If it is less than that, you will not see melena, you will see frank blood, right? And the minimum blood loss to manifest as melena, it should be 50 to 60 ml. It should be 50 to 60 ml. So if the blood loss is less than 50 to 60 ml, you will not see melena. Like if I bleed 10 ml, 15 ml, I will not see melena. So whenever a patient presents with melena, you learn three things about the patient. The first thing is he has got an upper gastrointestinal tract bleeding. Second thing, you get to know that bleeding has happened at least 12 to 14 hours before patient presented to me. And the third thing you get to learn is that patient has bled at least 50 to 60 ml and not less than that. Clear? Okay. Now, if I have the source of bleeding in the lower gastrointestinal tract, then I will probably present with frank blood in stool or minimally altered blood in stool, and we call that condition as hematochezia. Hematochezia refers to frank blood in stool. Directly seeing the blood in the stool instead of this altered black colored stool. And as we know, it indicates lower gastrointestinal bleed. Okay, I hope we have the clarity now. If a patient has got bleeding in the upper gastrointestinal tract, he can vomit the blood out. We call it as hematemesis. Or he can pass that blood in the stool. But if he passes it in the stool, if the blood has spent 12 to 14 hours in the GIT and the blood loss is more than 50 to 60 ml, patient will present with melena, right? If the quantity of blood loss is less, right, in that case he will not manifest with melena. In that case we call it as occult bleed. What occult means? Hidden, right? Not clinically apparent. Patient won't get to know that he is bleeding if the blood loss is less than 50 to 60 ml. Such cases, we will only get to know that they are bleeding when we look into the stool, right? Either we do chemical test to identify the blood or we do the microscopy to identify the presence of RBCs. If the patient has got lower gastrointestinal bleed, he will present with what we call as hematochezia or frank blood in stool. So if patient comes and says, sir, I went to bathroom and then I spurted out red colored stools or frank blood in stool, then you know that it is coming from the lower gastrointestinal tract. Okay, now that brings one important question to my mind. Can a patient with upper gastrointestinal bleed present with hematochezia? If yes, in what circumstances? And if no, well, let's move on to the next question. Let me say there is a patient who has got an esophageal injury and he has started bleeding from there. Okay, can he present with hematochezia instead of melena? Can he present with hematochezia instead of melena? Yes. Because for us to develop melena, there were two prerequisites. There should be at least 50 to 60 ml of blood loss and there should be at least 12 to 14 hours of time spent by the blood in the GI tract. If it is spending less time, then it will not be altered and you will be seeing hematochezia even when you have upper gastrointestinal bleed, right? So, if patient has got decreased gastrointestinal transit time, means intestinal motility is increased. If the intestinal motility is increased, then the blood is going to spend less time in the GIT and you will see frank blood even when they have upper GI bleed. Okay. Second, if there is massive blood loss, if there is massive bleeding, see patient bleeds 1 to 2 liters or 500, 600 ml, even that is massive blood loss. In such cases, the hydrochloric acid produced by your stomach, your bacterial activity and digestive enzymes may not be convert all that heme into acid hematin. So you will still lose frank blood in such cases, right? So in these two circumstances, when there is decreased gastrointestinal transit time or when you have massive blood loss in the upper GIT, you can still present with hematochezia. So if a patient presents with hematemesis and melena, it is very clear that it is a case of upper GI bleed. But patients presenting with hematochezia can still be a case of upper GI bleed. Now my question is, how will I differentiate in such cases, like a patient presenting with hematochezia? What should I think of? Whether it is upper GI bleed or lower GI bleed? How do I differentiate between these two? So I'll tell you one important point. Lower GI bleeds are generally not massive. Okay. And because of that, patients with lower GI bleed are unlikely to present with hemodynamic instability because they wouldn't have lost much, right? What is the most common cause for lower GI bleed? It is hemorrhoids. So patients with hemorrhoid lose some 30-40 ml of frank blood whenever they go to the bathroom. So they're not losing even 1% of their circulating blood volume. So their BP and other hemodynamic parameters will not be affected. But if I have an upper GI bleed and that is causing hematochezia, obviously I would have mostly bled massively. In such cases, my BP would have dropped. So any patient with hematochezia with hemodynamic instability, think of upper GI bleed. Any patient with hematochezia, hemodynamically stable, think of lower GI bleed. Okay, I hope the point is clear. Right, unconscious, low BP, shock, hemodynamically unstable, think of upper GI bleed. And hemodynamically stable, think of lower GI bleed. Okay. Now we know how to differentiate between upper and lower GI bleed. Let us also understand the common causes for upper GI bleed. The first thing that we need to know is what is the most common cause for upper GI bleed. The most common cause for upper GI bleed is, see, upper GI includes esophagus, stomach, and the part of duodenum proximal to the attachment of ligament of Treitz. Now tell me what could be the most common cause. Right, that is going to be peptic ulcer. The peptic ulcers account for more than 50% cases of upper GI bleed. So whenever you see a patient with melena or hematemesis, half of them or more than half of them are because of the peptic ulcers. Okay. Then comes the question, what is the second most common cause for upper GI bleed? The second most common cause for upper GI bleed, Nilanjana Roy, it is an important cause, but from the context of India, it is not the second most common cause. Mallory-Weiss tear is still relatively rare. It is the esophageal varices. When it comes to India, it is the esophageal varices. Why that is important? Because we have a lot of patients with chronic liver disease because of alcoholism, who will eventually end up developing portal hypertension and esophageal varices, which can bleed, right? There are plenty of other causes. One of them you mentioned, that is Mallory-Weiss tear. Okay, can anybody elaborate what is Mallory-Weiss tear? Mallory-Weiss tear, and then there is another entity called as Boerhaave syndrome. Boerhaave syndrome. What is the difference between the two? Mallory-Weiss tear and Boerhaave syndrome. Both of them are esophageal injuries. Both of them are typically triggered by a bout of severe retching and vomiting. A bout of severe retching and vomiting. The fundamental difference is in Mallory-Weiss tear, only the mucosa of the esophagus is torn. Means you know that esophagus, the innermost layer is what you call as mucosa, right? Then you have the other layers. So in Mallory-Weiss tear, only the mucosa is torn and from there you bleed, right? So Mallory-Weiss tear refers to mucosal tear following severe retching or vomiting. Severe retching or vomiting. On the other hand, Boerhaave syndrome refers to the complete full thickness tear of the esophagus, right? Means all the layers of the esophagus are torn through and through. So the esophageal content percolates or leaves the esophagus through this tear and goes into the mediastinum. And because of that, patients with Boerhaave syndrome lose more massively. They bleed heavily. Along with that, this entry of esophageal content and the GI content into the mediastinum can trigger mediastinitis, and because of that these patients will have plenty more other consequences, including the myocarditis, hypotension, shock, and also the risk of death. So Borev syndrome is the full thickness tear of esophagus, means all the layers are torn. This is a major medical emergency. Mallory-Weiss tear is not a medical emergency in most cases. Yeah, you can call it as transmural rupture or transmural tear. The whole thickness of the esophagus is torn. Okay. Now, can anybody list other possible causes for upper GI bleed? Yes, you can have gastric erosions or erosive gastritis, which is usually caused by NSAIDs. Even peptic ulcers after H. pylori, NSAIDs are the second leading cause, right? So these are all important causes for upper GI bleed. Okay. I will come to Meckel's diverticulum, right? So which part of the GIT Meckel's diverticulum affects? Which part of the GIT the Meckel's diverticulum affects? Which part of the GIT and which age group it typically affects? Okay. Okay, so I'll come to that. Now, apart from the listings we mentioned, there is something called as gastric antral vascular ectasias. How many of you have heard about it, or in which rheumatological disorders you have heard about it? Gastric antral vascular ectasias. Himanshu Chaudhary, right. So when we try to forcefully vomit, like even when you try to induce and vomit, or when there is severe contractions of your diaphragm and the abdominal muscles to vomit out, that can cause both Mallory-Weiss as well as Borev syndrome. In fact, I had a very interesting case of Borev syndrome where the patient was brought to the emergency room saying that he complained of chest pain and then collapsed. When he was brought to the hospital, he was in a state of shock, and an ECG was taken which showed some non-specific STT changes. And the emergency room doctor thought that it is probably a case of non-ST elevation MI. He got a troponin done and it was elevated. So he considered it as a case of non-ST elevation MI, sent it to the cardiologist. Cardiologist immediately took the patient to the cath lab, did the angiogram, and it turned out to be normal. Okay. After that, he get the patient back to the ward, and he thought it is probably case of what you call as the coronary spasm or Prinzmetal's angina, because in that case there will not be a clot or an atheromatous block. The blood vessel goes into spasm. That is why myocardium may not be getting sufficient blood supply, and that is why patient would have experienced the chest pain. That was the thought process. But few days down the line, patient's condition started worsening. He developed pleural effusion. Okay. Even then, the cardiologist thought that pleural effusion may be because of secondary to hospital acquired pneumonia. He asked for an aspiration. The pleural fluid turned out to be normal initially, but after that the condition started worsening further, and then they put an ICD, and the drain kept on draining, and it went on for few weeks, and the ICD drain did not stop at all. Multiple antibiotics, pleural fluid analysis, and did not stop at all. And that is where multiple other departments were given references to, and one department was gastroenterology. And the gastroenterologist thought probably there may be a fistula connecting the GIT with the pleural space, and that is why the patient may be having so much of pleural effusion not settling down. And all he did was ask the patient to swallow some dye, edible dye, and the dye appeared in the pleural fluid. Only then we know that there was some fistula, and when an endoscopy was done, patient had a Borev syndrome. He had a through and through or transmural esophageal rupture. And because of this communication, whatever food he was taking, partly it was going into the pleural cavity, triggering the pleuritis and thus pleural effusion. Even the fluid that he was drinking was also getting into the pleural cavity. And when we retrospectively visited the case back, we realized that the patient was having drinks with his friends on the terrace, and while drinking, he felt severe nausea. Obviously, many people after drinking, they vomit it out, right? But he tried to suppress it because he wanted to show off with his friends that he can take heavy loads of drink. That's one of the common tendency, right? We want to drink and we want to show that chadti nahi hai humko, right? I am used to it. So he was also trying to show off. and he was trying to suppress the vomiting, but then one severe bout of vomiting, he vomited. The crucial history that was missed by the emergency room doctor was that he vomited blood, which patient's attender did not give it to the casualty doctor. Casualty doctor also did not try to ask further about the vomiters, and then we literally got misled into the different direction, right? Okay, so upper GI bleed, peptic ulcer, Mallory-Weiss tear, Boerhaave syndrome, esophageal varices, erosive gastritis, then gastric Yeast-Nil angina, what you call as watermelon stomach, where you have some aberrant accessory blood vessels inside your gastric mucosa from which you can bleed. We call it as gastric antral vascular ectasia. It is typically associated with a rheumatological disorder which is called as, it is often seen in patients with systemic sclerosis. It is associated with systemic sclerosis. No, Nilanjan, the case was Boerhaave syndrome. So he had developed a transmural rupture, and the communication was created between esophagus and the pleural cavity. And the ECG changes we saw was because of the mediastinitis and myocarditis by the leaking of the acidic gastric content into the mediastinum. And that's why we had some STT changes, which misled us to consider the case as a case of non-ST elevation MI. Okay. Okay, then anybody knows what is Dilafoy's lesion? There is something called as Dilafoy's lesion. So some patients may have a aberrant blood vessel running just beneath the esophageal mucosa, and if there is small erosion of the mucosa, the blood vessel will be exposed and it can bleed. So we call it as Dilafoy's lesion, right? Submucosal vessel which can bleed. Okay, and then obviously esophageal cancers, stomach cancers, these are all important upper GI causes for bleeding. Point to note is peptic ulcers account for more than 50% of the cases. Okay. Now we have fair idea about how to differentiate between upper and lower GI bleed and what are the major causes for upper GI bleed. Now the next question is, when I clinically conclude that this is a case of upper GI bleed on clinical grounds, how do I further proceed, right? How to approach a patient presenting with upper GI bleed. So point number one, not all patients presenting with upper GI bleed are going to be critical. Not all patients presenting with upper GI bleed need to be treated inside the hospital. Many of them, like patients with Mallory-Weiss tear, we don't need to do nothing in most cases. All you need to do is reassure, give them pantoprazole prescription and send them home, right? So the first question is, when a patient presents with upper GI bleed, on what grounds I should decide whether the patient needs admission to the hospital and further evaluation, or I can manage it on outpatient basis. Whether I can manage it on outpatient basis. So first point, right? That is about decision to hospitalize. How do we decide to hospitalize? Obviously, it can't be a random choice. It's just like, okay, I feel that this patient should be in the hospital. All that doesn't work. It has to be very logical and objective, right? So how do we objectivize our decision? It is going to be based on certain scores. Okay. Now tell me, why should I hospitalize a patient presenting with upper GI bleed? Only if I am concerned about two circumstances. Circumstance number one, if the bleeding needs to be stopped by endoscopic or surgical interventions. Circumstance number two, if the bleeding needs me to transfuse the blood. If both are not required, I don't need to do any endoscopic surgery or a surgical intervention to stop bleeding, and I don't need to give blood, then there is no need for the patient to be in the hospital, right? So there is a score which helps me to decide the need for transfusion and need for endoscopic intervention, right? What is that score? Anybody has an idea what is the score used to decide about the hospitalization? The score is called as Glasgow Blatchford score. Glasgow Blatchford score. If the score is 0 to 1, then such patients do not require transfusion, and unlikely that these patients will require any endoscopic intervention. So in such cases, you can treat as outpatient because there is low risk of need for transfusion and need for endoscopic interventions. Need for endoscopic interventions. And if the score is more than 1, when I say more than 1, that means 2 or anything higher than that, such patients need to be admitted. It needs hospitalization. Hospitalization is needed because these patients have very high risk of need for transfusion, increased risk of need for transfusion. I will come to Rockall score also, right? And endoscopic intervention. The Rockall score is primarily used to understand the prognosis. It is not used to decide whether I should admit or not. It is for understanding the prognosis. Like, okay, I've got a patient with upper GI bleed. I've hospitalized him. Now the patient attenders will repeatedly ask me, "Sab theek hai na sir? Koi problem to nahi hai?" Now, how confidently I can tell them whether all is well or whether the patient is in trouble? Obviously, anybody presenting with a GI bleed is in trouble, but I can probably predict the mortality risk based on another score which is called as Rockall score. Rockall score is used to assess the prognosis. The Glasgow-Blatchford score is used to decide about the need for hospitalization. Okay, clear? Now let me take you through what important points we need to study from Harrison before I proceed further. So Harrison also talks about the same approach. Whenever we have a patient with GI bleed, we have to understand whether it is upper or lower. And he also divides the GI bleed into overt GI bleed. Overt means what? Obvious. Obvious GI bleed is when patient presents with hematochezia, melena or hematochezia. It is very obvious that patient has got GI bleed. And occult means hidden blood loss, where it is not clinically apparent and we get to know patient has got blood loss when he develops anemia or other consequences of blood loss. But otherwise direct evidence of blood loss is not there. Then we call it as occult GI bleed. Okay. Obscure and occult both are same, where it is not. Okay, I'll tell you one more point, Nilanjana. Obscure GI bleed is the term also used by some gastroenterologists to decipher or to imply that you have a patient with GI bleed and you have not found out the cause. Generally, how do we find out the cause? By doing an upper GI endoscopy if I am suspecting upper GI bleed, or a lower GI endoscopy if I am suspecting the lower GI bleed. If upper and lower GI endoscopy turn out to be normal but still patient has got a GI bleed, then most likely the source will be in that part of the intestine which is not easily visualized. Which part of the intestine is not easily visualized? Anything distal to the ligament of Treitz and anything proximal to the terminal ileum. Means your jejunum and ileum are not well visualized with the endoscope. So most likely patient will be bleeding from that site. Another possibility is Dilafoy's lesion. Dilafoy's lesion is very difficult to identify if it is not actively bleeding even for a skilled endoscopist. So if you have Dilafoy's lesion, or if the source of bleeding is from your small intestine, mainly the jejunum or the ileum, you may not be able to see it under the endoscopy. In such cases, the gastroenterologist label it as GI bleed but with obscure source. Okay. Now, the Harrison mentions about the causes or sources of upper GI bleed. He also clearly mentioned that peptic ulcer is the most common cause for upper GI bleed. Okay. And then he also mentions the other causes like Mallory-Weiss tear and esophageal varices. Okay. And then he goes on to elaborate a little bit about small intestinal sources of bleeding. That's what we were talking now, obscure GI bleed. Right? Small intestinal GI bleed, he says, may account for around 5% of all gastrointestinal bleeds. And the most common cause in adults are vascular ectasias, the tumors originating from the small intestine, like the GIST, gastrointestinal stromal tumors, carcinoids, adenocarcinomas, lymphomas and METs, and sometimes NSAID induced ulcers and the erosions. Okay. He also mentions that Meckel's diverticulum is the most common cause of significant small intestinal GI bleed in children. But in adults, the most common cause for the small intestinal bleed, which presents as obscure GI bleed, nothing found on the endoscopy, is not the Meckel's diverticulum. Meckel's diverticulum typically affects the small intestine and presents in childhood. So if a child presents with upper GI bleed, child presents with GI bleed, upper GI and lower GI endoscopy turns out to be normal, then first thing we should suspect is patient may be having Meckel's diverticulum. On the other hand, if an adult presents with gastrointestinal bleed and upper and lower GI endoscopy turn out to be normal, in that case, I should possibly suspect the vascular ectasias, small intestinal vascular ectasias. These are the most common cause in adults. Okay, clear? Now, when it comes to lower GI bleed, from medicine I want you to remember only one point, that is hemorrhoids are the most common cause for lower GI bleed, and a patient with hemorrhoid bleed generally does not present with hemodynamic instability. So anytime you get a patient with hematochezia and hemodynamic instability, always think of an upper GI source of bleeding for hematochezia. Okay. Now Harrison also goes on to discuss about the approach, and in the approach he says first thing is to assess the risk. When you say risk, what does it mean? We are talking about need for transfusion and need for endoscopic intervention, and he also follows the same thing. We will be looking at the Glasgow-Blatchford score. The possible score in the Glasgow-Blatchford score is 0 to 23. When the score is 0 to 1, the risk of need for transfusion or hemostatic intervention, that is trying to clip the bleeding vessel with an endoscopic procedure, is less than 1%. Such patients can be treated as an outpatient. But when the score is more than 1, then the risk of need for transfusion or the endoscopic intervention is high. Such patient needs to be hospitalized. Now the question is, what are the parameters that go into Glasgow-Blatchford score? Yes, the source of bleeding for the small intestine is usually one of the branches of the aorta, that is like the mesenteric artery, and in such cases the management is very difficult. Either we need to open the abdomen and then ligate the source of bleeding, or we have to embolize the artery which is becoming the source of blood loss. Okay, now what are the parameters that go into Glasgow-Blatchford score? That includes the blood urea nitrogen at the time of admission, hemoglobin, systolic blood pressure, heart rate, presence of melena, presence of syncope, presence of liver or cardiac disorders, right? So for all these parameters there are scores assigned, and all I want to know is whether the score is more than 1. If the score is 0 to 1, outpatient treatment, more than 1, inpatient treatment. Okay, now once that is done, we have decided when to admit, whom to admit. The next thing is, how do we approach further? Okay, now that I have decided that this patient needs to be hospitalized, after that what is my next step? I have to go for the endoscopy, right? See, you might say, sir, Rockall score also can predict the mortality. So if the mortality is high, that means the patient needs to be admitted. Then why are we not using Rockall score to decide whether we should admit or not? Why are we relying on Glasgow-Blatchford score? The reason for that is this is a very simple tool that does not include the endoscopic observations. So in the emergency room, without endoscopy, I can decide whom to send home and whom to hospitalize. But once we have hospitalized, the next step is to go ahead with the endoscopy, right? So we have to go ahead with the upper GI endoscopy. And from the upper GI endoscopy, generally the diagnosis will be clear, right? Whether I have Mallory-Weiss tear, whether I have Borhave syndrome, or whether I have peptic ulcer, or whether I have esophageal varices, because these are the leading causes. And once the endoscopy is done, how do I proceed further? For that, there is a flow chart or algorithm in Harrison. Let me try to simplify that for you. So when you look into Harrison, he gives you a small algorithm or an approach to a patient presenting with upper GI bleed. Okay, so first thing I want you to see is when there is a erosions in the GIT. Erosions in the GIT are relatively very safe, unlikely that this patient will bleed heavily, or unlikely that this patient will develop hemodynamic instability. So any patient with erosive gastrointestinal bleed needs no endoscopic intervention. So all we need to do is give them pantoprazole or other PPIs once a day orally, put them on regular diet, and discharge them after the endoscopy. Simple. Okay. If the diagnosis is Mallory-Weiss tear, most of the patients with Mallory-Weiss tear at the time of presentation will not have active ongoing bleeding. When they retched, When they traumatize the mucosa, they would have bled a little bit, and after that generally bleeding stops, right? So when I do endoscopy, I will see a small linear mucosal tear. Okay, such cases do not require any active intervention because there is no active bleeding. For such patients, we give an antiemetic so that he doesn't vomit again and cause more tear. Send him on regular diet, and we can discharge him after the endoscopy. No need for anything more. Mallory-Weiss tear is generally safe. Okay. If there is an active bleeding, we might require the endoscopic therapy, which accounts for less than 5% of patients of Mallory-Weiss tear. What we do if there is an active bleeding, we put staples, right? If, let me say, this is the esophagus, okay, and there is a small tear here. So around the tear, we put staples. See, any of the PPIs can be used. Okay, so in terms of superiority, pantoprazole is more effective in suppressing the acid production than omeprazole. That's why it has become the standard PPI of today, right? So what we do in endoscopic therapy, if there is a Mallory-Weiss tear and there is active bleeding, so the tear will be stapled. That's the basic approach. After that, obviously, we will put the patient on an antiemetic. We'll ask him not to take any solid food for a day, and in such cases, we might have to hospitalize. So hospitalization in Mallory-Weiss tear is required for less than 5% of the patients. 95% of the patients who do not have an active bleeding, neither they require an endoscopic intervention nor they require hospitalization. Okay. Then, if I have ulcer, which as we know is the most common cause for upper GI bleed. If I have an ulcer, I have to obviously treat the ulcer. How do we treat? We facilitate the healing by giving acid suppressive therapy and also eradicating the H. pylori infection, right? That is pretty simple. But patients with the peptic ulcers, if they bleed once, they have a very high risk of re-bleed. So whenever I make the diagnosis of peptic ulcer on the endoscopy, I have to think of what is the risk of re-bleed to decide further management. Now, how do I get to know the risk of re-bleed? That is again an important MCQ. There is a parameter to decide the risk of re-bleeding in a patient with bleeding peptic ulcer. Anybody knows what is the tool used to assess the risk of re-bleeding? Right? Upper GI bleed, as I've already told you, if there is erosions, what to do? If there is Mallory-Weiss tear, what to do? And if there is peptic ulcer, right? So if there is peptic ulcer, I need to assess the risk of re-bleeding. We have to assess the risk of re-bleeding. Okay, how many of you know this thing called as Forrest classification of bleeding peptic ulcers based on endoscopy? This is based on what is called as Forrest classification. So when it comes to gastrointestinal bleeding, plenty of these scores and naming parameters come into picture. We call it as Forrest classification. Okay, so I'll show you what Forrest classification looks like. So according to Forrest classification, a patient with bleeding peptic ulcers, the endoscopic appearance is divided into different classes. Okay. MW stands for Mallory-Weiss tear. That typically happens when you forcefully vomit or retch, and that severe retching increases the intra-abdominal pressure so much so that you end up developing a small tear in the lower esophagus, especially the GE junction, only affecting the mucosa, not cutting through all the layers of esophagus. We call it as Mallory-Weiss tear. Okay. So Forrest classification, the ulcers are classified into 3 classes: class 1, 2 and 3, and these classes are further subdivided into like 1A, 2A, 2B, 2C and 3. Okay. Now the Forrest class 1A refers to when you have a blood vessel which is actively spurting. When you look closely here, you can see that there is one pichkari of blood, right? Actively splurting blood vessel. So if right now only blood loss is going on, obviously there is a high risk that the bleed will occur again, right? This is what we call as Forrest class 1A. Okay. Active spurting blood vessel. Then Forrest class 2A. What do I see in 2A? There will be a visible blood vessel but which is not actively bleeding. Means I see an ulcer On the base of the ulcer, there is a blood vessel which is visible, but it is right now not actively bleeding. But if the ulcer has eroded to reach a blood vessel, it will bleed again for sure, right? So when you look at this risk of bleeding, if there is an active spurter, 60% of those patients are going to come back with another episode of bleed. If there is a visible blood vessel, close to 50% of these patients are going to come back with another episode of bleeding. Okay. Then Forest 2B, you can see a clot on the ulcer base. So this is the ulcer where you can see a blood clot. Now, if the blood clot gets dislodged from that location, it will bleed again. So there is still a good risk of bleeding in Forest 2B. Okay. Then you have a Forest 2C, where you see a small dot on the ulcer base. This carries a very low risk of bleeding. The small dot is because there was a small amount of bleeding which has been now contained, and that bleeding is created as very small clot, very minimal small clot, which doesn't look like a proper clot. You just see a small dot on the ulcer base. We call it as Forest class 2C. This carries relatively low risk of bleed. And if you see an ulcer which has a clean base, you don't have a clot, you don't have a visible blood vessel, right? You don't have a dot, nothing, clean base, carries the very, very low risk of rebleeding, right? So whenever I diagnose that patient has got upper GI bleed because of the peptic ulcer, I have to look at the endoscopic images to decide which Forest class it belongs to. And when you look into Harrison, he follows the same approach. If I have an ulcer with clean base, which is Forest class 3, right, which has a very low risk of bleeding, such patients do not require any endoscopic treatment. All I need to do is give them daily pantoprazole treatment or any other PPI, regular diet, no dietary restriction, and I can discharge them after the endoscopy because they have a very, very low risk of bleeding, as you see from this graph, right? Clean based ulcer, that is Forest class 3C, Forest class 3, sorry. On the other hand, if there is a flat pigmented spot, that is our Forest class 2C, right? Flat pigmented spot. In those cases, there is no need for endoscopic therapy, once daily PPI, but because slight bleeding has happened, I could see a small flat pigmented spot, we will give small dietary restriction, only clear liquids for a day. We will observe for 1 or 2 days in the hospital and then discharge. If I see a clean base, discharge. If I see a flat pigmented spot, then I will hospitalize for 1 to 2 days and give clear liquids. No other active intervention needed. But when I see an adherent clot, right? Adherent clot, that is 2B. If there is an adherent clot, that is going to be 2B. Okay. And if I see a non-bleeding blood vessel 2A and class 1, which is a spurter, these carry very high risk of rebleed, right? So in that case, what Harrison suggests is, if I see an adherent clot, I might have to consider endoscopic therapy, give IV PPI treatment, not oral, okay, and then clear liquids only for 2 days, and patient should be admitted because there is a very high risk of rebleeding. And if I see a active bleeding, that is spurting vessel, or a non-bleeding but visible blood vessel, there is definitely close to 50-60% risk of bleeding. These patients require endoscopic ligation or the injection of the glue or other substances to block or stop the bleeding. We need to inject some glue, or there are various other substances that can be injected into the blood vessel to prevent the bleeding. So these patients will definitely require hospitalization. These patients will require IV PPIs, dietary restriction, and hospitalize for 3 days. See, the surgical resection of the bleeding segment of the GIT is generally not required in today's context. In the past, when we had an ulcer, we used to resect the ulcer segment and then create an anastomosis. Those are not required in today's context. The vagotomy and other major surgical procedures are very rarely performed because one major change happened in last 2 decades, that is the discovery of H. pylori as the leading cause for peptic ulcers. In the past, what used to happen was, you give them some antacids, the ulcer might heal but recur again, newer ulcers would come, and the condition used to get terrific, and we used to usually do surgical procedures including cutting the vagal supply to the GIT. But that is not required now because we can comfortably eradicate the H. pylori, and mostly the patient will not have major troubles after that. Okay. So that will be an approach whenever we have a patient presenting with ulcer as the cause for upper GI bleed. All I need to do is do a forest classification to understand the risk of rebleeding, and if the risk of rebleeding is low, that is the clean based ulcer or fat pigmented spot, there is no need for endoscopic intervention. If there is an adherent clot, active spurting blood vessel or a visible blood vessel might require the IV PPI and the endoscopic intervention. Clear? Okay. Now we have understood the forest classification. We have a fair idea about how to approach a patient presenting with upper GI bleed. Before we wind down, I will take you through one or two important MCQs. But before that, one quick summary. So whenever a patient presents with GI bleed, the source of blood loss can be upper GIT or lower GIT. And when we say upper GIT, we are referring to the portion of the GIT proximal to the attachment of ligament of Treitz. Means if you have an esophageal pathology or the stomach pathology or the duodenal pathology, mostly it is counted as upper GI bleed. And anything distal to the ligament of Treitz, mainly the rest of the small intestine, that is jejunum, ileum and the colon, will come under the lower GIT, right? Now when it comes to lower GIT, the entire colon and terminal ileum can be visualized through the colonoscopy, and the entire upper GI can be visualized with the help of upper GI endoscopy. But the jejunum and the ileum may not be well visualized, so if bleeding happens from that side, we will not be able to find it on the endoscopy. So in that case, we will label it as obscure GI bleeding. Such cases, I have one question: how I can identify the source of blood loss, source of bleeding, from where, whether it is the jejunum or the ileum, from where the patient is bleeding, how do I identify? So there are two approaches. Okay, one is directly doing the CT enterography, which can help you to localize the which blood vessel is responsible for the blood loss and what is the site of bleeding. There is alternative approach, which is what is called as capsule endoscopy. Means now we have small capsules which have the camera. So instead of having a tube with a camera on top of it and trying to insert it from the top or from the bottom, we can ask the patient to swallow a capsule which is a disposable capsule which has a camera, and it has NFC or Bluetooth. So as patient swallows it, it will start taking the pictures and it will send the pictures to a device outside which is connected to the capsule through NFC or Bluetooth. And as the capsule travels through your jejunum and ileum, it will capture the pictures and send it to us. And now we can identify from which source the bleeding is happening. Okay, so those are two approaches when your endoscopy fails to reveal the source of bleeding. Okay, now coming back to the peptic ulcer. So if I have a patient bleeding from peptic ulcer, step number one is to assess the risk of rebleeding based on the forest classification. And if there is a high risk of rebleeding, patient requires IV pantoprazole, requires endoscopic intervention and hospitalization. If low risk of rebleeding, maybe OPD treatment and oral pantoprazole. Clear? Okay. Now what about the patients having the esophageal varices? What Harrison says about it? All the patients with esophageal varices need hospitalization and need intervention. What is the intervention? Intervention is called as EVL. What is EVL? EVL refers to endoscopic variceal ligation. So what you do is, there is a tortuous vein from which we will be bleeding. So they take small rubber band kind of things and deploy those at the base of those distended or tortuous veins, so that the blood flow to the veins is cut off. And slowly this remaining portion of the vein, now because it is not getting blood supply, right, the vein will get thrombosed and then shrink and slip off. That is what we call as endoscopic variceal ligation. So all patients with the esophageal varices will require endoscopic variceal ligation. Until you get that done, right, you might need to stop the ongoing blood loss by giving drugs which cause vasoconstriction like octreotide, or nowadays instead of octreotide we prefer a drug called as terlipressin. Octreotide or terlipressin can be given. They cause vasoconstriction, so the esophageal variceal veins will also get constricted, and from if the blood supply to those veins is reduced, obviously blood loss will be reduced. Okay, clear? Now let me take you through some of the MCQs which are repeatedly asked in your NEET PG, INI CET as well as during your case presentations and bedside discussions. So here is the first one. Which of the following is the most common cause for small intestinal bleed in adults? When I say small intestinal bleeds, I can also call it as obscure bleed because they will not be evident on the upper or lower GI endoscopy. Right. Meckel's diverticulum is the most common cause for small intestinal bleed in children. And when it comes to adults more than 40 years of age, it is going to be small intestinal vascular ectasia, small blood vessel anomalies of the small intestine. And I think all of you know Janker's diverticulum has nothing to do with the bleed. Ulcerative colitis can cause bleeding, but remember, ulcerative colitis, we say colitis, it does not affect the small intestine, it affects the colon, right? It can cause bleeding, but colon, obviously that will be lower GI bleed. Okay, here is one more question. Which of the following score is used to assess the need for hospitalization in a patient with upper GI bleed? We have Hasbled, Chartwood DS2 VAS score, Glasgow-Blatchford score, and Rockall. And I think all of you know it. It is going to be Glasgow-Blatchford. The same question can be twisted to ask you which of the following score is used to assess the need for blood transfusion in a patient with upper GI bleed. Again, it is going to be say the Glasgow-Blatchford score because this predicts the need for transfusion. They can also ask you which of the following score predicts the need for endoscopic intervention in a patient with upper GI bleed. The answer is also going to be same Glasgow-Blatchford score. Okay, so there is one more question now. In which of the following circumstances upper GI bleed can present with hematochezia? This is one of the common bedside question. The moment you say, sir, this patient presented with melena or hematemesis, the examiner will ask you, can a patient with upper GI bleed present with hematochezia? If yes, in what circumstances? So please remember, for the blood to become melena, right, heme to become acid hematine, it needs to spend 14 hours plus time in the GIT and blood loss should be 50 to 60 ml or more. Please look into the options. Can a patient with gastric outlet obstruction present with hematochezia? Unlikely, right? Means if your GIT, the stomach outlet is blocked, then obviously the blood is going to spend more time in the stomach, right? And most likely a patient with gastric outlet obstruction will vomit out the blood rather than present with melena or hematochezia. He will vomit out. Hematemesis will be the presenting method, right? If there is decreased gastric transient time, decreased gastric transit time means what? Less amount of time is being spent by the food or the blood in the GIT. Means that transit time is shorter. Obviously, we will not be able to provide 14 hours required for the heme to become acid hematine. In that case, yes, the upper GI bleed can present with hematochezia, right? Not the increased gastric transit time. If the transit time is increased, obviously it is going to spend more time inside the GIT, right? And then if there is massive upper GI bleed. So B and D are appropriate answers. So in that case, option E is something that we should be going for. Sutapa, hematochezia refers to presence of frank blood in the stool instead of an altered blood, directly seeing clear frank blood in the stool. We call it as hematochezia. Okay, so this kind of summarizes our approach to upper GI bleeding. But because someone had spoken about Rockall score, we will spend 1 minute talking about Rockall score and then we will wind up for today. No, so if you are bleeding less than 50 to 60 ml, it will not lead to hematochezia. It will lead to what you call as occult bleeding. You will not be able to see the blood at all, neither in altered or direct form. It will be occult, hidden. Only under the microscope you will be seeing RBCs in the stool, or when you do chemical test to identify hemoglobin in the stool, it will turn out to be positive. Right, so when, let me write it down here only. So when the blood loss is, if less, it will lead to occult bleeding. Occult means hidden. You will not be able to clinically manifest with it, right? Okay. So one last score that I want you to study today is what is called as Rockall score. Rockall score. This is primarily used for prognostication to understand what is the risk of mortality in a patient presenting with upper GI bleed. So if this score is more than 5, the patient's risk of death is very high because of the blood loss. Now what parameters go into Rockall scoring? Age of the individual, presence of certain comorbidities, whether patient has shock at the time of presentation, and what is the source of bleeding, and whether there is any stigmata of recent bleeding. Okay, so if the age of the person is less than 60, obviously the chances of death is less, so the score will be 0, right? If the age is higher, we will give higher score. Presence of certain comorbidities like congestive heart failure, ischemic heart disease, renal failure, liver disease increase the risk of death when they start bleeding, so we will give higher score. If patient is in a state of shock at the time of presentation, obviously the risk of death is higher, so we will give higher score. And most importantly, the source of bleeding. We have just learned that Mallory-Weiss tear is a benign disease, doesn't cause major problems, right? So if patient's reason for upper GI bleed is Mallory-Weiss tear, we will give very low, 0 score, right? On the other hand, malignancies continue to bleed profusely, so we will give higher score. And if there are other diagnoses like esophageal varices, gastritis, peptic ulcer, in all those cases we will give 1 score. And another important endoscopic observation is the stigmata of recent bleeding. What is that stigmata of recent bleeding? Means if there is an adherent blood clot or a visible bleeding or non-bleeding blood vessel, that means there is a very high risk of rebleed. Such cases we will give some high points. Collectively, if the score is more than 5, the risk of mortality is high. Such patients carry poor prognosis. If the score is less than 5, the risk of mortality is less. They carry better prognosis. So at least this will help me to counsel the patient attendant saying that the score turns out to be bad, so I cannot give you a positive hope. We will be doing our best to manage the case. If the score is low, means less than 5, then you can kind of reassure saying that things appear to be better and we are managing and we are doing our job. One last question I have before we wind up. When do we transfuse the blood? What should be the hemoglobin level to decide that we need to transfuse the blood? What is the threshold for blood transfusion? Should I transfuse the blood when the hemoglobin level is 10 or 11 or 12? See, normal we know, right? 14 to 16 is the rough range. Transfusion threshold. Threshold means what level we think of blood transfusion, right? Transfusion threshold for hemoglobin in upper GI bleed. So please remember that is 7 grams. So when hemoglobin is less than 7 grams per deciliter, we have to consider the transfusion. Okay. One last question. Less than or equal to 7 grams. One last question. Once, okay, hemoglobin has dropped to 7 or less than 7, I have to give blood transfusion. What should be my target hemoglobin? Should I take it to 14, 15 or 10, 11? What should be my target hemoglobin? So please remember guys, the target and the threshold is same, that is 7 grams. Means anytime it drops below 7, give the blood transfusion to bring it to 7 or little more than 7. We don't need to aim for 10, 11, 13, 14, 15. The reason for that is 7 grams is generally sufficient to sustain the functioning of vital organs. So maintain it 7 gram or more than that and treat the underlying problem from where the blood loss is happening. Once you patch up the blood loss, slowly body will synthesize more hemoglobin and it will come back to normalcy over time. So we don't need to aim to get the hemoglobin level to normalcy, right? 7 is the transfusion threshold. You have to maintain 7 plus. If there is an acute loss where body probably may not have time to adjust to the lower hemoglobin, like in the variceal bleeding or peptic ulcer bleeding, you may consider 10 to 12. If any patient who has got chronic blood loss, like the patients with gastric antral vascular ectasias or the intestinal vascular ectasias or ulcerative colitis, in them we don't need to even aim for 10 to 12. 7 is sufficient. Treat the underlying cause, body will take care of the rest part. But if it is acute loss, yes, you can aim for 10 to 12. Never aim for the normal hemoglobin. We don't need to reach the hemoglobin value of 14 or 15, because the more you try to transfuse, you also run the risk of transfusion associated complications. Okay, good. So that's it for today guys. That was about the upper GI bleed. And yes, any patient right? Whether acute or chronic, if the hemoglobin is less than 7, then the oxygen carrying capacity of the blood is so depressed that it may not be able to deliver sufficient oxygen to your vital organs. So that is why anemia can start leading to heart failure. It can start leading to impaired neurological functions. It can lead to impaired liver and renal functions. So we need to maintain 7 plus. If there is acute blood loss, we need to maintain slightly higher, because all of a sudden hemoglobin is dropped and your organs and systems are not accustomed to such low hemoglobin. If there is chronic blood loss, in that case your body will also be accustomed, and 7 is generally more than sufficient. Okay, so that's it about the upper GI bleed. The next session will be on pleural effusion, because weight loss we have already done. So the next session we will be planning on the pleural effusion, which is day after tomorrow. That will be more clinical, because pleural effusion is less theory and more clinical. This was more or less a theory topic. So it is better if you read a little bit mainly from the clinical books and then come. We will be having a good discussion. Thank you guys, and I'll see you in the next class. Till then, have a good time. Good night. I think the murmurs is on the 9th, I guess. Okay guys, have a good night. See you soon. Bye bye.